I'm Daisy Fancourt and I'm a Professor of Psychobiology and Epidemiology. Welcome to my exp. Social prescribing is a means for individuals to be connected to non-medical forms of support within the community. So this can be everything from arts to nature to voluntary and community groups, to also things like advice for benefits, for housing, for other social challenges they might be facing. And it's a really innovative idea because it's strengths-based. It looks at what the assets are in communities that we can be drawing on to support health and healthcare. It also focuses on what's important to individuals, what matters to them, thinks about what their goals are, what their needs within their lives can be. Social prescribing has arisen from a recognition that actually we don't always have medical solutions to problems, and sometimes problems don't need medical solutions. Estimates are that somewhere between 20 and 40% of GP visits are actually not for medical reasons, but they're for social reasons. And when people present with certain problems, for example, mental health problems, whilst there might be medication or psychotherapies that can be helpful, we also have to acknowledge that those problems are rooted in people's contexts. There could also be issues with housing, with social isolation, with benefits that might need to be sorted as well if we're going to help people and give them the best possible chance of recovery. So that's where social prescribing is so innovative, because it actually provides an opportunity to think, as well as the medical, what else can we be bringing into the picture that might be providing those health solutions. The most common model of social prescribing is that a patient will visit their GP, who will recognise that they could benefit from the scheme and will refer them to someone called a link worker, who has expertise in all the different kinds of activities available in the community and can provide a combination of signposting but also motivational coaching and support that might actually help them to recognise which activities are best, how they can overcome the barriers to engaging, and actually looking over perhaps multiple consultations at whether the programme of activities that they're thinking of is helping. But it's not the only model, and actually what we see is there are many other ways that people can engage in social prescribing. They can refer themselves, they could be referred through social care or through voluntary organisations. And we're also starting to see even more plurality in terms of whether link workers are involved or whether there are other kinds of trusted individuals who might be supporting somebody in engaging. Social prescriptions can be anything from attending arts or music or heritage or culture activities in the community, to going to other nature-based or green activities or exercise programmes. It can also be referrals to job centres, to benefits advice, to lawyers for legal support with social issues. It can also be really tiny steps that are necessary to achieve that. Some social prescriptions are for a bus pass, so that somebody is actually able to get to town centres where some of these services might be available. For some people, social prescribing can involve one activity, for others it involves lots of different things. And sometimes we see people engaging in social prescribing just for a few weeks to get the kind of support they needed, whereas for others it can be something that they continue doing as a way of helping with the long-term management of their health and well-being. So to give you an example of how it works, within the trial that we've been leading within my team, which is looking at young people, so adolescents with mental health problems who are on child and adolescent mental health service waiting lists, as young people have been entering the waiting lists, we've then been approaching them through their clinical staff within their mental health service and asking if they'd like to be involved in social prescribing. If they've then said yes, they've been connected to a link worker who's been specifically trained in how to work with young people and also has really good knowledge of which activities in the local community could be appropriate and supportive for young people given the particular vulnerabilities they're experiencing. The young people have then had up to 6 sessions with those link workers, sometimes online, sometimes in person, depending on their interests and needs. And in those sessions, they've done things like talk about their goals and aspirations. They've done gentle creative activities to sort of put the young people at ease. And they've helped them to map out a kind of roadmap for where they want to get to and what kind of steps could be helpful along the way. What's been really good about this as well is because it's been integrated with the waiting list, there's been lots of safeguarding and support. If the young people start to experience more problems, this can be referred back to the clinical staff within the mental health service. And we have some really lovely case studies and examples of how this has worked. So then when we think about the question of, well, does social prescribing as a whole mechanism work for particular health conditions, we also start to see some really interesting results. So one of the very early trials on this, way before the national rollout in the UK, looked at whether people who are presenting to their GPs with low-level mental health problems and social needs could get benefit from being referred through to voluntary organisations. So things like Alcoholics Anonymous or mum and baby toddler groups or job centres or other kinds of third sector support. And this actually found that these referrals were leading to improvements in mental health, reductions in anxiety. They were also leading to a greater ability for individuals to carry out their day-to-day tasks. So a whole range of personal and functional outcomes. Already some studies at local levels have shown that if people engage in social prescribing, they actually tend to reduce their levels of GP visits and A&E attendances, particularly for those people who actually had very high levels of those attendances in the first place. And we're currently doing some really exciting, very large-scale national analyses looking at how social prescribing affects people's well-being levels and what the economic implications of this are. One study of this that was looking at green social prescribing specifically showed really clearly that people who received green social prescribing had subsequent improvements in their well-being, and they were able to equate this to a saving of over £2 versus every £1 that was being spent on the programme. Within the UK, we already have a national programme of social prescribing, and we're starting to see similar large-scale change occurring in other countries too. Around 40 countries are now delivering it already. In Greece, there are currently a big pilot looking at a national scheme for people who have mental health problems. There's other really exciting work underway in other places as well. We've been collaborating with colleagues in Singapore who are looking at similar large-scale programmes, this time linked in with secondary care for people who have had hospital admissions. Moving forwards, there are definitely some really interesting directions that social prescribing is going in, one of which is more of a kind of left shift model. We're recognising increasingly that actually people don't always need the link worker to provide that kind of support. Sometimes the activities themselves, if people are already engaging in them as part of their day-to-day lives, can be preventative, helping to stop people developing the problems that mean they'd need to be entering healthcare pathways at all. So there are some regions of the UK that are actually now piloting programmes where they are putting money directly into the voluntary and community sector organisations to try and achieve this primary prevention objective. And these schemes are actually part of a new innovative model that's happening in the UK, which is to try and develop a social impact finance model. Only around 25% of health outcomes are actually attributable to healthcare, whereas we know that around 50% of health outcomes are actually caused by social and environmental circumstances. But the way that we proportion health budgets is completely the opposite of that. So what I would be saying to governments is, can we be more radical in this? Instead of cutting budgets to the community sector at times of austerity and then ending up with health services that have got more and more people that are needing their support, could we be investing substantial funding into those community organisations in the first place, trying to achieve that left shift and hoping that the more preventative approach might reduce the actual demand we end up needing in the health service at all? For many people, social prescribing is a new thing that they've only heard about recently, but the whole concept of social prescribing is actually what healthcare used to be centuries ago, the idea that community was providing support that was so important for us. So actually, far from being a new way of thinking, it's more of a return to an older way of thinking that we seem to have stepped away from as we've moved more and more towards biomedical considerations of health. So I think it's really valuable for us as we're looking forwards to really bear that in mind and recognise that social prescribing, yes, is an innovation, but it's also a fundamental approach to health that we need to reconnect with.